Most of you know me. I'm Gary Raff. I'm one of the cardiothoracic surgeons. It is my pleasure to introduce Frank Ng, who's the Chief of Pediatric Cardiology here. Frank is a PGY 33, and he comes to us most recently from CHLA, where he was the Chief of Peds Cardiology there. Frank, we actually tried to recruit him previously as Chief here, and he had just taken the job at CHLA. But their loss was our gain, so to speak. So Frank is internationally known in pediatric cardiology circles. He's a very innovative interventional pediatric cardiologist, and he's going to talk to us today a little bit about just one small piece of his practice, which I would not have believed was possible 10 years ago. So I'd like to introduce Frank Ng to you.
Well, thanks for the introductions and thanks for inviting me to give grounds. You know, I've done this for 25 years and I've given a lot of grand rounds, but this is definitely a first, giving a surgical grand rounds. And I feel like I'm a Shark Tank here. Anyways, I just remember medical school watching surgical grand rounds, getting people, well, not surgical, the surgical M&Ms. It was definitely a shark fest back then. Seemed pretty benign here, though. Anyway, so I'm going to talk to you about a topic that is dear to me. It's something that we've worked on for probably a decade now. And I know that in the surgical field, this is something that you probably have not seen a lot of, but I think that all of us at one point or another have come across this as a problem, either during training or as a staff. And the problem is that you find venous obstructions that you encounter at different times, but that patient needs IV access, central line access. And then what do you do with that? So what I want to really talk about is some of the changes in the paradigm. At least I'm trying to convince people to think about veins, obstructive veins, in a little different way. So this is the current paradigm. I call this kicking the can down the road. All of us have encountered this. You take care of a patient in the hospital, you have an IV, the IV gets blown. What do? You just find another IV. You pull that old one out and you just move on with life. Right? Sometimes you have access problems, and at least at this hospital, there's a PIC team, right? A team that specializes putting in long lines that can give you the central line access. Of course, this is a surgical grand rounds, and most of you guys would then, instead of doing that, maybe call the surgeon and put a line in yourself. But usually, once the line is in place, you forget about that old vein that was gone, and you go back to taking care of the patient. You don't think about that vein anymore. You take care of the primary disease of the patient. Well, okay, so the surgeons gain access, no big deal. But what happens when the surgeons can't gain access? And we've seen this a few times, especially in pediatric surgery. Then suddenly you're in big trouble, right? So this is the paradigm I face in the cath lab. We've encountered cardiac patients that have had surgeries, multiple caths since infancy. If we go in to do a heart cath and we find that the vein is occluded, we pretty much say, let's go to the other side. And that happens to a lot of us. If both sides are occluded, we say, okay, let's go to the neck, get to the IJ. If both IJs are gone, then what do? Maybe a little bit of a problem at that point. Well, we get pretty creative. We'll go transhepatic and get into the heart that way. What happens if the vein is too small for a large delivery system for an intervention, or you need dual access? That becomes a problem. At some point, some of these patients will run out of venous access or develop signs or symptoms of venous insufficiency. That becomes a problem. So out of necessity, we've learned how to recannulate some of these vessels and, in fact, rehabilitate them so that we can use them again in the future for future caths or to prevent symptoms. Now, who are the kinds of patients that would develop this? Well, they could be asymptomatic and they just happen to need central lines, or they have a chronic line that run out of venous access. Most of these patients have chronic diseases. They could be congenital heart disease patients. They could be premature infants, patients who are on TPN or are IV dependent. Usually these would be patients with short gut syndrome. You can have cystic fibrosis patients, hem-onc patients. Then there's another group of symptomatic patients where you have IVC or IVC syndrome. You also have a group of patients that have thrombophilic problems. The problem is that it's not a problem until it becomes a problem. Then it becomes a big problem. So this picture reminds me of what the photographer is thinking right after he snapped his shot. And this is what happens when you run into this problem. It's a big problem. So here's an example of femoral vein obstruction. You can see the venous collaterals going beyond the obstructed area. Here's an example of an iliac vein obstruction. Here's an example of a distal IVC obstruction. Here's an example of combinations of venous, iliac, as well as mid-IVC obstruction. Here's a huge obstruction in the proximal IVC. These kids aren't doing well. The profile of the patient with that subdiaphragmatic occlusion, as I said, are usually, you'll find them mostly in the femoral veins. Again, at least in my experience, patients with chronic diseases, multiple history of multiple line placements, and femoral obstructions, instrumentation, especially as an infant. The clinical signs of venous obstruction depends on the location and extent of these obstructions, whether it's acute or chronic, and the development of adequate collaterals. Now, usually in infancy, they don't have much symptoms because they can rapidly develop venous collaterals. The problem is that when they get to teenage years, they go through a growth spurt, the limbs lengthen, and suddenly those venous collaterals are not big enough, and now they start to have venous insufficiency. But early in life, they don't have those symptoms. So here's an example of the supradiaphragmatic group. With here's a patient with an old SVC baffle, a mustard baffle, and a patient with transposition of the great arteries. Here's another example of a glen that has obstructed from the upper vessels in the SVC. You have innominate vein obstructions from a pacing wire. Here's an example of subclavian obstruction, IJ obstructions. You have patients with thrombophilic syndromes who probably represent the most difficult group of patients. They have obstruction all the way up to, from the femorals all the way up to the iliacs and into the IVC. And then you have patients like this where the orthopods and the vascular surgeon I've seen, the Paget-Schroeder patients with the subclavian vein is obstructed between the first rib and the clavicle. So here's the patient with some of the thrombophilic syndrome, the factor V Leidens. They show up with vessels like this, where there is no IVC. Everything is based on collateral flow. And I'll show you some of the examples. For the profile of the supradiaphragmatic obstructions, you'll develop SVC obstructions. Again, patients with congenital heart disease who've had their subclavians and IVC and IJ access. Transvenous pacemakers, again, the detranspositions with atrial switches, the mustards, sending operations. The patients with history of chronic lines in IJ or the SVC. Again, these could be premature infants who need TPN, IV access. The clinical signs, I'm sure you've seen this at one point or another. They tend to be very extensive, involving IJ, subclavians, and the SVC. They tend to be chronic. Typically, if it's just one vein, patients don't have much symptoms because they'll develop the collaterals. So here's a recent case. I just wanted to highlight to illustrate the point. 5-year-old patient who was an ex-premature baby, had history of necrotizing enterocolitis, now with short gut syndrome. The surgeons have removed a large gut, a segment of gut. History of multiple line infections, and she's lost her vascular access all except for one line. This remaining line was in the left IJ, and that became infected. I remember the service tried to treat this with antibiotics, treat through it. 2 weeks of antibiotics, and it was still positive cultures. Somebody remembered me doing something like this, so I got called about this. I brought the kid to the cath lab, and this is what we see in the femoral. So this is a long segment stenosis in the right femorals, and then the rest of it is obstructed. Here's the left, and this is what we were trying to, we ran a wire up there, opened that back up, and you see this is contrast, all staining the IVC. Basically, there's no flow through this vessel. Here's the left side. And in fact, this side has a much more extensive collateral system you can see here. But these patients' legs look pretty normal. So here's just one of the ways we use hydrophilic wires, and we'll make our way up through these occluded vessels, and we'll twist and turn, and there's a little bit of BF&I, brute force and ignorance. And you'll make your way up there, and there he goes, up in the IVC in the right atrium. And then, of course, when you take the picture, you'll see this long segment of what had been an occluded IVC. And of course, once the wire's in place, you can run balloons there, dilate it all up, and then of course, you'll see this sort of a little bit larger vessel, but with the vascular recoil, this is useless because once you take the wire out, this will then go away again, it will rethrombose. But at some point, you go past this, and usually it's above the renal veins where there's a lot of blood flow. IVC is pretty normal here. So here we have 157 centimeters length of occlusion. And then of course, this is where the infected line is. We go in there and we see that this thing, again, is also obstructed there. The innominate vein is obstructed. And you have, again, lots of paravertebral collaterals. We get up to from the IVC that we've opened up, and we find this area of occlusion here. And you'll see that from the left IJ, you can see that the area of occlusion is quite short, actually. But it's there, and he also has a left IJ stenosis. Again, the surgeons had actually tried to put in the line in there, just was not able to get, you can get the vessel, but can't get the line in. And this is the reason why. When you take these pictures, you'll see that it's just long segment stenosis. And so, of course, we'll go in with these tiny wires and poke our way through this area of obstruction. You see the wire bend at the site, but eventually we get ourselves past through there. We take a snare, we snare that wire, and then we pull it out of the femoral vein here. So now we form a veno-venous loop here, and then you can run a catheter. You can see where the arrow is the obstruction. But a little brute force, we can get past that obstruction, and we'll make our way past that area up into the IJ. So with that in mind, knowing that the kid's infected at this time, we weren't going to put any stents in, but we used this passage to put dilate it up, and just by a little more time, you see what the vessels look like still. Again, you see, in spite of what looks like an adequate dilation, the vascular recoil would just close this up. So this was not going to last very long, but we opened it up, and we actually put a new line in here. This is after the infection had cleared now. So we go back in, and we put this line in, and for some reason, PICC lines can go into places you don't want, but because we have a snare, then we can get it back into position. So now we actually have a new line through the area that had been occluded. Meantime, because the IVC had been occluded, we hadn't done anything at that time. We had left the central line in there to treat the infection, and now the infection is clear. We put the new line in the upper body, because you know that a femoral line is not the most sterile place, right? This is where you pee and poop. And so we put stents in here in the femorals, from the IVC all the way down to the femorals, and we have established flow to this vessel here. So now, if the patient has another infection, you have another pathway to get your line in. So we actually wrote this up as a indication for this kind of aggressive management in these TPN-dependent patients. Now, up until that point, I hadn't thought about this procedure in non-cardiac patients. This has always been, I've published in cardiac journals, but this is the first time I realized maybe there's a need for this in non-cardiac patients. In fact, when we did a little more literature search, here's a paper that it says indications for pediatric intestinal transplant, and this is a position paper from the AST. And if you read through this, it says life-threatening complications warranted consideration for intestinal transplant, and some of the indications include the threatened loss of central venous axis. Imagine you're going to get an intestinal transplant because you didn't have a central line. That's just nuts. So here we are, just another example. Sometimes you find these incidentally with no symptoms. So you have this sort of occluded femoral vein, and you can see how there's a long segment of stenosis. Now the body will create venous collaterals like this. They usually go around the vertebral bodies. We call these paravertebral collaterals. But again, using wires and stiff dilators, we can make our way through the occluded segment, get to the area where there's some good flow, and then now you're able to run a wire through and reestablish that connection. Here's the lateral projection. Again, you see the sort of beak. If I see the beak, I have 70% chance of success of getting through this, because you can wedge that little wire in there and just make your way through the vessel that has been occluded. This patient had RPA stenosis. We ended up ballooning that. Then on the way out, we stented the whole vessel. And this is the red arrow is the segment of stenosis that we had to get through before we get to the iliacs and then to the IVC. 4 months later, the RPA had re-stenosed, and we brought the kid back in, and you can see this follow angiogram. There's a nice thin intimal layer within the stent, but it's patent. We go back in there, and this time we just stented the pulmonaries. In fact, this patient also had SVC stenosis from a previous cannula from bypass, and we opened that up as well. And this is what it looks like. And again, we brought the kid back in for further dilation because the babies are growing pretty rapidly and the veins grow. So then we brought the kid in. Just you can show that there's patency over time. Sometimes you look at this, you see, wait a minute, there's no blood vessel there. How are we going to get through this? But if you look very carefully, you'll see this little tiny beak. That's what you got to look for. If you see that, you know that there's a good chance you can get back through that vessel. And then this is what it looks like after you've stented that area. On the lateral, you don't see the beak. And so this is where I try to convince our adult colleagues, sometimes you need biplane because you don't see a beak there. But on lateral, you see this tiny little beak. And if you see that, that area is a segment that had been occluded, and the body formed this posterior paravertebral venous collateral flow. And this is what it looks like after you put that stent in. Another example, when you take these pictures, you'll see this sort of rat's nest of collateral flow. But if you slow down the pictures and you record this, you'll find a frame before the collateral vessels show up where the beak is there. You see it on the AP, you see it on the lateral. And of course, we can dig our way up there to the renal veins. In this particular case, we end up putting 7 stents in, open it up. Now, this kid has a hypoplastic left heart syndrome, had a Norwood. He's going to need multiple operations to get him back to a single ventricle repair. This patient, the same patient 12 years later, there's patency of this vessel. Again, you see there's collateral flow. That tells me that this vessel now needs to be made bigger. So we basically dilate it up. You notice that the venous collateral is no longer there because it's going through its normal course. 17 years later, this is what we still have. So by this time, the patient's an adult. And this is to show that you can have long-term patencies in these venous stents. Another example, it could be very complicated. So there's another patient with double outlet right ventricle, had a Fontana operation, has now protein-losing enteropathy, and we're going to have to deal with this. But you see that there's venous obstruction here on the right side, on the left side, and it gets up to the IVC as well. And in this particular case, we ran a wire through there, and you can see that there's a segment of stenosis in the distal IVC in this region here. But you're able to run sheaths to both sides. And I know that this is done in the aortic side among the adult interventionists. This patient actually had a coarctation, so we went ahead and stented the coarct, LPA stenosis, we stented that, and then venous collateral that made him cyanotics. We got rid of that, and on the way out, we stented the IVC, and then here we are putting bifurcating stents in both iliacs. You can see how you can actually form these bifurcation stents and just re-establish that flow that had been lost probably years ago. Here's a patient who had transplant, and again, as an infant, it's not very common, but it happens, and of course, they lose their vessels to their chronic lines, and in order to do the biopsies, we got to get that through. So we put a stent in. Every time I brought the kid back up, the stent had totally occluded, and the reason is because there was poor inflow. If there's no inflow, the stent's going to re-occlude. But the good thing is that that stent acts as a target. As long as you see the metal on fluoroscopy, you just take a needle and just poke right through, and you get back to the vessel that is open, and now you can go back in. Over 5 years, you see I have to use a longer needle because as they grow, the limbs extend, and it looks like the stent has moved up into the pelvis, but really just a part of the growth. But you can get your way back into the catheter, and here's just an example where the long needle can get us past that area of occlusion and to get back to the patent IVC and use that as a pathway for biopsy. This is a patient that we had done here within this year who has a genetic syndrome, a very malformed chest wall, also a complicated heart lesion that Dr. Raff had repaired. So the heart is fine at this point, but because of the abnormal chest wall, just cannot leave the ICU because of the pulmonary respiratory issue. But you can see how a long segment of stenosis from all the way up to IVC, we balloon this up, and you get a little bit of improvement, but not good enough, because when you pull this wire, it'll go away. We end up putting a PICC line here, and for this case, just because we needed a line for access at this point in time. So what happens is that the old paradigm is that we would have pulled that line, the vessel would have gone. This particular case, however, the kid had a line infection, and somewhere along the line, the message to say, call me to look at this, was lost, and the line was pulled. But this is the new paradigm. If you actually have this, get an ultrasound and look at those veins, especially if you know this is a kid who's going to need multiple lines. When I say kid, I mean patient, because I always call every patient a kid, even if they're old. So don't just remove the line just because the patient don't need it, because you may be able to rehabilitate that vessel. Beware when lines are pulled, because that's when the vessels get lost. Consider anticoagulation if the thrombus is new, and if the thrombus is old, you can rewire this, balloon it, if you have to stent it, unless it's infected at that time. So this patient had that line pulled and was forgotten. 2 months later, go back in and you see the vessel that we had pulled out. This is what it looks like, because you can get through it when the line is there because there's still a remnant tunnel, but once you pull that, it goes away. And now trying to dig through this takes a lot more time than if you just ran a wire through that a small tunnel. We get through here and you can see there's some staining because sometimes you do extravasate, but it's a tiny vessel, a tiny wire. low pressures, you can come out and try to find your way back in. And see, that's where the wire goes to. And I thought we were in a good position, but we actually stained it. But actually, if you look at where the contrast is, it's in the vessel up until this point. A little, we call these flush wounds, to come out and just find it again. And here's the other side. Actually, that's patent. But if you come across here, you see where the iliac vein had occluded. So now having that, we can come in from the other side, from the contralateral side. You can see that two wires are pretty close to each other, but not quite connected. But because you have a target now, you can run your wire through that, and then you get back to the IVC that way. This is that vessel that you have, the remnant occluded vessel that had been there. Again, we balloon this up. We see some improvement, but not good enough. And then here, that's when we start to stent these. This was a less than a year-old child, and we were able to get it back to rehabilitate that vessel again for future use. Sometimes these occlusions occur up in distal IVC. Look at this. You know, this is totally asymptomatic, but I know over time the abdomen, the lower body is not going to do well. You form these collaterals within the liver, in fact. This is another heart patient that had multiple cats at another institution. Didn't expect this, so we had to turn our focus to this and, again, find our way through these little clotted IVCs, reestablish that flow, and stent it. And then go back in over time, balloon it up. This patient had other interventions that are left out, but basically access is preserved. You get back to the heart, not to mention some of the problems. This is an interesting patient, 19-year-old senior in high school, factor V Leiden, previously undiagnosed, comes in with a swollen leg on the right. He thought his leg was swollen because he was right-handed, and that was his strong leg. But he did notice that when he played baseball, when he ran the bases, he got very fatigued on that leg. Well, this is what it looks like. The whole vessel is occluded. And again, that's when the hemophilic syndrome was diagnosed. He had factor V Leiden deficiency. The left side actually had been also occluded, except that had more collateral flow, so it wasn't so bad. It didn't have the symptoms. The problem was really worse on the right side. You see how when we're making our way up there, the vessel is just remnants of whatever had been there before. Everything is going behind the spine, goes up the azygos system. But we're able to make our way up there, balloon that up, and see how the azygos system, it doesn't go into the heart, it goes behind the heart and actually will dump back into the SVC. That's how he got his lower extremity venous blood back into the heart. But in this case, we're able to reestablish that IVC flow. And then, of course, again, because it's actually involving both iliacs, we end up putting bilateral iliac stents as well. And again, you'll need dual axis, but once you get that back up, you see how you've preserved that flow after 12 stents in 8 hours. This is what it looks like actually right afterwards. Now, it's not perfect, but it's better than the pre. And then, of course, 3 months later, I brought him back because I was really worried that it might have some, because of his thrombophilic syndrome. He's back on he's on anticoagulants, but I wanted to make sure those vessels were wide open, and we just further dilated it just to buy more diameter. 1 year later, we did the same thing, just ballooned it all up, and this is what it looks like at the end. And this is what it looks like 2 years later. It's almost normal at this point. And actually, he went on to the University of Hawaii and played varsity baseball. So that was a nice save. Another patient with factor V Leiden, and you can see how extensive these thrombophilic kids can have in their venous obstruction. We open that up. Again, this is not perfect, but it improves the symptoms, and this is the varicosities the patient had. This is what it looks like afterwards. Supradiaphragmatic venous obstructions. Here's an example of a Glenn shunt that had completely obstructed. See how the blood cannot get back into the heart from the SVC. It makes its way down to the IVC. It makes its way up there. Of course, the head is swollen, and I'm sure the brain is under higher venous pressures. We can open that back up. This is what the patient can look like. You notice it doesn't look that bad until you see what it looks like. You see the subtle swelling, and then you see what it looks like after the swelling is gone. They actually look different. Another patient with SVC syndrome, this is what the patient ought to look like. This is 1 day later. You see the big difference in the swelling. This is a nominate vein obstruction after pacemaker that was pulled out, and you see some clots and some just chronic obstruction. Again, you can get that through, open that back up, put your new lead in. Another patient with SV syndrome with a mustard operation, complete obstruction. The vessel drains by azygos in the back. See the contrast back here. And this time it's so obstructed, we end up taking a transeptal needle and just poking right through. Now we have this catheter in the heart, so we have a target to aim. And then you get back in, reestablish that flow. And in fact, this patient also needed a pacing system, and we actually put that into into the heart transvenous pacemaker. Very sick, bad patient. Had transposition, had a great repair from another institution, but lost all the major vessels, and the kid had edema, ascites, just all over swelling. And you see that this patient had severe SVC syndrome. There's obstruction of the SVC, the subclavian doesn't drain anywhere, and you can see that it just goes down through collaterals and finally makes its way back into the heart. But this is where the obstruction takes place. This is actually posterior from the back. You don't see it so well here, but here we are trying to find our way up that occlusion, and you have an IJ. You can always find something in one of the veins, but you see here's the obstruction here. And we can make our way up to the heart, just pushing further and further up, and then finally you get above the clavicles, and now you're at the base of the skull, and you can see this remnant vessel here. This is where the obstruction is, and in fact, contrast starts to flow a little more freely up here. We'll make our way up there, and you see that there's more free flowing up there, balloon this whole area. And then we take all these pictures. This is 5 hours later, but it looks pretty easy, but it's not. So here we are, open that back up, open up the SVC. Sometimes you'll find little thrombi here that you can actually suck out. And here's some examples of the thrombi you remove. And now here we are, once we open that up, we're going after the innominate vein also. And see, we find our way through that obstruction, get to the left IJ now, and we balloon that up as well. And this is what it looks like afterwards. Here's the final stent procedure. Remember what it looked like before. And what's interesting is that I actually did this just to see what would happen. You see this pitting edema from the upper body. This is what it looks like 1 day later. On the red arrow, you notice that the edema is not so bad. In fact, the face is looking more normal. 3 days later, the face actually looks more normal, and you don't see the pitting anymore. So in 3 days, you've gotten rid of all that extra interstitial fluid just by opening up the venous obstruction. This is what the baby looked like at first. This is what the baby looked like a few days later. 3 months later, we bring that kid back in for assessment, and we see that this time we added stents into the innominate vein. Remember, we had just ballooned that. We had stented the SVC only. And by doing that, 10 months later, we can rehabilitate these vessels. I always worry about trying to be doing too much and cause a tear. So you put what you could put in, bring them back in, and make them bigger over time. And this is what it looks like at the end. So 3 years later, you see this patency of that vessel, patency of the IJs in the innominate vein. You can further dilate this. Obviously, you want to put stents that can get to adult size, so you have to pick the right stents. But this is what the baby looks like 9 months later, 1 year later, 2 years later, 3 years. Now, again, she doesn't have those obstruction SVC syndrome anymore. So it's actually very satisfying to know that you can actually help with these vessels. A patient with mediastinal lymphoma, another 19-year-old. This is interesting. This patient came to me from Arizona. And basically, you see this occluded SVC, occluded IJ, subclavian. We actually put the stent in the SVC, opened back up. What was really interesting is to me, I didn't pick this up until afterwards. This is a picture beforehand. You notice that the neck is a little bit swollen. You see the venous engorgement on the chest. This is what like after. You see that there's better definition of the mastoid muscles, the sternocleidomastoids, and that the venous vessel over the superior chest is no longer there. In fact, he told me that he had been wearing Velcro shoes for the last few years because he couldn't bend down to tie his shoelaces, and he never slept flat. He had to always sleep sitting up because he would feel really bad when he lay flat. He comes into the clinic the day later and just show me he can bend down, he can lay flat, he can buy shoes and tie his shoes and not have to use baby Velcro shoes. So we brought the kid back up. Remember, we spent more time on the SVC, but now we can actually go back into the innominate vein, snare it the same way we had shown earlier, dilate that area up, and now we totally reestablish venous flow. And again, this is from probably whatever venous reactivity from his radiation therapy, from his lymphoma. You've seen this in some of the orthopods here. If you're here, you have Project Schroeder's patient come in with a severe swollen right arm. He's a pitcher after a game, and you notice that the subclavian had a clearly obstructed. And again, this is the problem at the obstruction between the first rib and clavicles. It's a surgical procedure because they have to remove that rib. But in the meantime, you can actually clean this out so that you can preserve that vessel. Because even if you get rid of that obstruction by removing that head of the rib, that vessel could disappear. And you may get lucky and develop collaterals, but why? If you're there, you can use TPA to melt some of the fresh clots in. In fact, just want to show you some of the thrombectomy techniques here. You can run your catheter up and down. There are different types of thrombectomy catheters we can use to slide up and down and suck those clots out. You see the clot right there, you can suck out. And then you can add your infusion catheter to put a TPA. Those are some of the clots that we pulled out. Angiojet's a great little toy that you can use you can see the clot. We put contrast just to show you can see how you can just suck out that clot. And now it's gone. So that's the arm before. You see the subtle swelling, and then afterwards you see the little more definition in the musculature. Again, he wanted to play baseball. He's going to want to continue to pitch. We thought it'd be good to get rid of that obstruction, and then the orthoped took care of the obstruction. Mitochondrial disease is one of these really bad things in pediatrics. It's a multi-system problem, and you see that this can need central lines for all kinds of medication, but you can form clots there. But again, you can use these thrombectomy catheters to try to remove some clot. In fact, this is what that looks like. You can go up and down that vessel over a wire and suck out clots. Another system, the penumbra system, you can see how it works here. You just stick that thing in and just start to pull out the clot. It works very nicely. So we have a lot of toys. I'm sure you do too. So here are some of the combinations. You have new clot, which looks like sorry, let me get back here. Here's the new clot, and there's some of the old clot that looks very whitish, very vibrant looking. That's old. In this particular case, we ended up putting stents in the innominate vein and open that back up again. So here's actually, I'm almost done. This is the most complicated kid I've ever treated. Mitochondrial disease with dysautonomia, multiple endocrinopathies, including diabetes, had intestinal dysmotility, so was totally TPN dependent, had ostomy bag, had recurrent kidney stones, bilateral nephrostomy tubes, von Willebrand disease on top of that, another immunodeficiency disorder, has intermittent hypertension, chronic pain, asthma, atopic dermatitis, chronic SVC. This patient actually is the only patient I've seen that needed 3 central lines because all these medications had to be given IV and there were some incompatibilities. So he needed 3 lines. So this is the transport of the systems that he came in on. You imagine how much medication is going through those central line. Sitting up, you notice that his eyes look like this. Once he lays down, he starts to get really red and bloody looking. And that has to do with the fact that there's venous pressures. Here are the 3 lines that he had in him. You see this giant clot sitting right here. Now, how do you fix that? Because you have 3 lines here. You can't take out the lines because if you did, he needs it during the procedure. But if you put a stent there, you're going to trap those stents. So what do? We had to get pretty creative. Here's the gradient. We came in from above and below. You see there's a 10 millimeter gradient across the SVC. So that's significant because it's venous pressures. We actually took a snare and just pulled those 3 lines out of the IVC area where the clot was. So I just pulled it out. Now we have access to that clot, and then we basically stented it. And then after that, we put the 3 lines back in. And you kept the snare, you take a tip deflector, and now you pull that vessel, and you can bring it back through. And now he's got that 3 lines in, but you have a stent on the outside protecting the area. So this is what it looks like after with the 3 stents. Again, no gradient afterwards. And this is what his body looked like beforehand. See all this superficial venous, and this is what it looked like right afterwards. Again, not perfect, but you see an immediate improvement right away. So let me just summarize that occluded venous vein stents can occur outside of congenital heart disease. That was a aha moment for me when I did that first patient. Luckily, these occluded veins, even if it's chronic, can be recannulized and stented safely and effectively. Stented veins can be life-saving for some patients who are TPN or central line dependent. Signs and symptoms of venous insufficiency can be relieved. And the paradigm shift is that don't give up on these occluded systemic veins. So I think that the shift of that paradigm should be to be more aggressive at treating venous obstructions. We're not talking about little peripheral veins. We're talking about central veins, especially those patients who need chronic indwelling lines and lifetime. Don't be satisfied with just finding another vessel. Think about recannulizing these obstructive veins. If it's a new thrombus, you can treat it medically. You can use mechanical thrombectomy. If it's chronic, you may have to recannulize it, angioplasty it, stent it, and then obviously follow up with medical treatment. So before you pull these chronic lines in, take a picture and see what you got, and you may be able to rehabilitate this. So for some of the trainees here, I know you've chosen surgery, and I know that you love this field, but just to let you know, this is how we train our pediatric interventional cardiology fellows. This is how we teach them. Okay, thank you. Any comments, questions, challenges? Yes.
I've seen this problem a lot in dialysis patients. I'm wondering, what is your experience when you have to go across the floor?
That's a great question. Now, I have not taken care of a dialysis obstruction from those shunts that you guys put in. Some of these patients, when they go up the neck, definitely is a problem. So if we had to, I haven't done this a lot. I've used self-expanding stents. They'll crush, but they'll open back up. The nitinol wires are pretty resilient, so I wouldn't use stainless steel stents. I try not to put those, I'll just balloon them up, but if I find that if I have to keep going back to deal with this, then we'll end up putting a self-expanding stent in place. Yes?
What does the pediatric surgeon do who encounters the multiple line patient, whether it's an oncology or a gut patient, and they find themselves, is there a way to anticipate that they're going to need this intervention? Because many times it happens, you go to the OR, you access a more peripheral vein, you find you can't pass the wire, and maybe you've got access to the vein, and you squirt some dye in, and you find that collateral is an occlusion. What do you do in that case? Is there a way to avoid that trip to the OR before, without, and call you ahead of time?
Well, this is why I call this a paradigm shift. I mean, obviously, there's a lot of patients there where the vessels are gone, and then you end up trying to get something through that. The hope is to try to avoid this in the first place, and that's why even now, when we have our pediatric patients in ICU, we know that these kids will need a line access for one reason or another, whether it's heart disease or other disease. I ask them that before you just pull it, take a picture, because as long as that little remnant lumen, which is the size of the catheter that you've just pulled, if you can get through that, you can balloon that up and buy yourself a little more real estate and preserve that. Again, I would say that you have to anticipate that this is a patient who might need that line, right? You kind of know that depending on the medical diseases of that patient. But rather than just pull it out, put a wire through, take out it, put a little sheet and take a picture first. Because you can actually avoid a lot of this if you are proactively thinking about that.
But for forever taking out lines that are infected, and so before you go any line, then one of those patients call you?
Well, that's what I've asked. Again, I don't want to be totally busy dealing with vessels, right? Because I'm a heart specialist. But at the same time, I know that this is one of those areas where if you anticipate it, it's better to take that picture and do something to rehabilitate that vessel before you just yank it out. Because almost 100% of the time you pull that, if you were to take a picture, the lumen is the size of the catheter you've just pulled, and those will always clot pretty much. But you have a few weeks before it becomes organized and fibrotic, which then becomes a lot harder to go through. I can't say that I've been successful 100% of the time. If I see a beak, I have about 70% chance that I can get through. But I think that this can be life-saving for some of those central line TPN-dependent patients. Yes?
Have you seen problems with ECMO patients? Neonatal ECMO or adult?
Yeah. In fact, that sometimes on ECMO, they tie off the IJ, right? And now suddenly, again, with a single vessel, most of those patients are going to be fine because they'll just cross to the other side and make their way to the left side. The problem is that when you tie off a right IJ, let's say for an ECMO, and then you put a central line on the left side, now you better make sure your nominate veins patent. That was one of the patients we've seen. So if you're going to know that you're going to ligate this and get rid of that, because that's what you have to do, don't put the central line on the other side because you do run that risk. But yeah, we've seen that. And if you've tied it, I've actually had occasion where it was ligated but not divided. We can get back through those. And even if it's not a perfectly a lumen of equal diameter, you can still preserve some flow and put a stent there and open it back up a little bit. But certainly prefer you not to divide it.
You know, the sense I've gotten, Frank, from working with you with some of these patients is that the surveillance is really important. Do you have an algorithm that you use depending on age, or is just your gestalt?
Well, for the larger patients, again, if I can get the stent to about 8 millimeters, the chances of reocclusion is pretty low. Now, you'll always find a little 1 or 2 millimeters endothelium inside the stent, which is fine. But until you get to that, I usually first I'll bring them back within a 6-month period, just take another look. And as I said, if it's totally occluded, I try not to get it to the size of the vessel that was there before, because then you run the risk of tearing that. You put something in, let it endothelialize, and then go back and further dilate it over time. It's like skin expanders, right? You don't just expand it to the size you need. You take time for the body to adjust and further dilate it. As far as anticoagulation, the typical ones are just some baby aspirin. I found that to be helpful. But for the ones that we have thrombophilic syndromes, and we know that, then sometimes I'll add Plavix and sometimes even Coumadin or Lovenox. So yeah, there is a variety of ways to manage this proactively. But even then, we've had kids who will reocclude, and then you have to go dig it out again. The thrombophilic syndrome kids are the ones that I have the hardest time, because they're very extensive. They usually don't show up until they have some signs of venous insufficiency, and then by then it's been years since they've lost those vessels. The body has an amazing way of forming collaterals, but the time when I find them is usually during the teenage growth spurt year, where the collaterals are not enough to manage the venous return with the fast-growing limb. Yes?
Given your discussion of collaterals and kids and stuff, you imply that something we see in adults, Phlegmasia ceruleus dolens, doesn't occur in kids, and that there may be some sort of age threshold at which you see that. Have you ever seen Phlegmasia in a...
Okay, I'll claim ignorance. What is that?
Oh, that's acute thrombosis of the deep, and if it's ceruleus dolens, both the deep and the superficial veins are occluded. There's a ceruleus alba dolens, where it's just the deep and the superficial veins are still spared. It's sort of a continuum of a process. But it sounds like Phlegmasia isn't occurring.
No, we don't see those. No, and in fact, a lot of this is just found incidentally, because in the cath lab, that's my first experience. You take a kid to the cath lab because you have to get a heart cath before surgery, and we find this, and it's because the kid had another surgery. The kids have an amazing way of developing venous collaterals, and most people will just use symptoms to make a decision. And my paradigm shift is that don't always just look at symptoms, because they will develop collaterals that won't show up with venous insufficiency. It shows up when they're teenage, when they're going through the growth spurt. And by then, you're 10 years out, and then trying to dig through that is not that easy. So that's why, the other thing I didn't mention is that, we use a lot of ultrasound to look at it, but I've also learned that ultrasound is not foolproof. I've seen a lot of false negatives, meaning they'll say, oh, there's flow there. And you go in there and say, I don't see any flow. It's a collateral that they're looking at. They don't know that's not that collateral. It's not the real vessel that you're looking for. So I've seen a lot of false positives. I've had the one kid here with the SVC, with the head was up to the size of the neck. They said it was normal. I said, there's no way it can be normal, because look at the baby, right? You have to tie the symptoms to the findings. And they were looking at the azygos, making its way down posteriorly. But yeah, we use ultrasound as a guide, but I always look at it with a little bit of hesitation. But yes, you're right. Pediatric patients don't tend to develop venous insufficiency where there are signs and symptoms, unless it's very extensive. And if it does, it's usually SVC, not IVC. I think that the stenosis happens from the line placement, and it can propagate, but usually stops below the renal veins, because there's so much blood flow coming back that you don't get that. But having said that, I have seen a few above that, and I think the clot started above, as opposed to starting from below and propagating up. That's just a theory. I don't know that for sure. I haven't seen a lot of those to be able to study it. So I'm hoping you guys will at least start rethinking what to do with occluded veins and don't ignore them because they can be salvaged, especially in certain high-risk patients.
Great, thanks, Frank.
Thank you.